Yeah, good evening, everyone. Once again, thanks for joining in. This should be a short session. We have, I think, 5 cases because of the 1 week interval. So, without further ado, we'll start off with the first case that is from, New Delhi. If Dr. Sayoni is there, Dr. Sayoni, over to you.
Yeah, good evening to all. So, this is a 8 years old girl who is born out of a non-consanguineous marriage. So, the clinical phenotype of the girl is that there is delay in attainment of all milestones, both motor and cognitive and speech. Currently, she has now intellectual disability. On examination, she has a microcephaly. She has some coarse facial features with bushy eyebrows and a broad nasal bridge. A short stature is there, and she has a early handedness, and now on examination has a right hemiparesis. Otherwise, the most evident clinical feature which was evident in her was a ataxia, which was chronic and it was non-progressive. Otherwise, she doesn't have any organomegaly or metabolic decompensation, and there is a younger sibling in the child who has a cleft lip and cleft palate. So, in the investigations, Dr. Nihal, can we see the investigations?
Okay. Okay.
So,
Uh,
so yeah, you can.
yeah.
So
Maybe I
there.
can show the MRI first.
Yeah, sure.
Okay. So, yeah, with that clinical picture, the scan was done, and on the scan, on top, we have diffusion sequences. There's some degree of hyperintensity over here in the frontal lobes on both sides, the white matter and the cortical surface. Cortical structures have these changes. So it does not truly restrict on the ADC sequences, but there is some hyperintensity out there. Predominant changes are in the symmetrical globus pallidus. They are, I mean, you can appreciate the edematous changes on both sides. Coming down the temporal lobes also, you see the cortex is slightly bright. We'll have a look at the T2s and flares if it's still persistent, if there's still edematous changes out there. But again, the midbrain structures is involved, the dorsal brainstem central tegmental tracts is involved, possibly also the mammillary bodies, the optic tracts are involved. So you can see on the ADC sequences, there is a mixed pattern of diffusion abnormality. The outer layer is slightly demonstrating low signals, whereas the internal ones have mild facilitated diffusion. The midbrain also, again, mixed pattern of reversal on the ADC sequences. Cerebellum also, again, you can see there's some degree of volume loss, will be better appreciated on the T2 sequences, but yeah, some cerebellar hyperintensity on the DWI sequences. So corresponding T2 axial sequences, again, you can appreciate the predominant changes of the edematous globus pallidi. They have the hypothalamic region out there, and cerebellar atrophy with these brainstem signal changes. The SAG better demonstrates the atrophic changes of the cerebellum. Also, the brainstem, especially the pons, is slightly hypoplastic. Corpus callosum also is reduced in caliber, especially in the anterior mid segments. Again, you can appreciate the contrast of the volume change of the supra and infratemporal structures. Cerebellum is demonstrating atrophic changes. I don't think a spectroscopy was done, and there was nothing on the DRE sequences. So these are the image.
No
Sorry.
spectroscopy was done. Yeah.
Yeah.
Hmm.
Yeah. So these are the changes we have. A predominant central changes, predominant symmetrical changes in the deep brain nuclei, involvement of the brainstem, cerebellum, and some degree of involvement in the frontal lobes. As you can see also over here, there is some shading of the T2 signals on the frontal lobes on either side, which is also seen on the diffusion sequences. So with that, investigation was done. Yeah, Dr. Sayed.
Yeah, so we had, seeing the MRI, we had suspected a neurometabolic cause or a mitochondrial cytopathy likely. So the arterial lactate was 2 and the ophthal did not show any optic atrophy. And in view of short stature, everything was done. All endocrine workup was done, which was normal. So actually this family was absolutely non-affording. So we had we couldn't send both mitochondrial and whole exome sequencing because we were expecting most of the mitochondrial would be nuclear, and we sent a whole exome. So that showed a homozygous deletion of chromosome 11, which was involving exon 5 of ACR3 alkaline ceramidase. And it was mentioned in literature as an early childhood onset progressive leukodystrophy. But when we reviewed the case reports which were published, so there was not much, only there was some periventricular signal changes, and the phenotype was also not partly matching. However, in this disease, they have mentioned about short stature and coarse facial features and all, but with a relative macrocephaly. but this child had a microcephaly. So my question to the house is that what are the if mitochondrial disorders are the possibilities? Like first, if anyone has experience with this particular mutation, because for us the imaging features what I had reviewed was not matching completely, and second, clinical phenotype was partially matching, and second, if we are suspecting a mitochondrial disorder, then what would be there beneficial to send a mitochondrial panel, because most of them would be nuclear and would have come on a whole exome.
Okay. So as you mentioned, to Stephanie, in literature, these were the cases or references which I could find. They had atrophic changes, the periventricular white matter changes, but none of them had any deep brain nucleatory abnormalities or
Yes.
signal changes in the brainstem or cerebellum. So considering the predominant changes are in the deep brain nuclei, we will go with the findings of pyruvate dehydrogenase deficiency related disorders or mitochondrial disorders. Spectroscopy might have been helpful, but these are the differentials for, I think, your case, primarily dealing with global status changes.
Yes.
Fatty acid oxidations and can also be considered. So looking at that case, I remember one of your cases only, which we had discussed previously.
Oh yeah, so this was also had come in a whole exam. So all the disorders which I mentioned, I had also reviewed back to your slides. So all this would be covered in a whole exam.
Okay.
So,
Okay.
so my question was that can we point to some specific mitochondrial disorder? Then we would be sending a mitochondrial gene panel as well.
Okay. All right. So the imaging had some matches. So yeah, I just remembered this case from our
We
previous
also
discussion.
thought, but she's a girl child, so
Okay.
PDH is usually X-linked.
Yeah. All right. I'll open the case for any further suggestions.
I have no experience. I cannot really contribute. As you said, it's not completely matching the present case with the literature.
Yes, sir. It's not matching. So, apart from PDH deficiency, like it would have come in a whole exam. So any other mitochondrial disorder specifically we can point out? Like usually the MELAS and all those things would come in a mitochondrial panel, but not in the whole exam. So any other mitochondrial disorder? Or any point in doing a MRS? Because the MRI and exam, everything we had done free for this child because their family was absolutely not affording.
No, I don't think MRS is now required. It looks like a metabolic cause.
Yeah.
Even the cerebellar atrophy also, that is one pointer to which favors mitochondrial.
Yes.
The question is there hemiparesis from honors?
She had early handedness, but she didn't have any stroke-like episodes. And this, I was most thinking of like a PDH-like picture in this case.
I mean, MELAS, I think I have not seen any cases with
Yeah.
symmetrical involvement of the deep brains. Spine screening done for LBSL.
LBSL, the MRI is not.
Yeah, MRI doesn't match for LBSL.
Doesn't match for LBSL actually.
And microcephaly is also not the feature of MELAS.
Yeah.
Fatty acid disorders study?
Sir, it would have covered in my whole exam. Yeah.
Okay.
We didn't do a TMS, GCMS, but the basic metabolic workup but she didn't have any decompensation history, no episodes of any hypoglycemia, nothing. We did a basic metabolic screen, so that was normal.
So the mitochondrial 37 genes, the 4 are the famous ones. So MRF, MELAS,
Yes.
then you still have the 33.
Yeah.
Which are not covered.
Yeah. So I was just asking, would we still pursue for the mitochondrial panel and
should be pursued because that is only going to finish.
Yeah.
Because complex 1, 2, they can have such changes.
Yeah.
MRF, there are no features to suggest short stature and I don't know MRI changes in MRF. Because he has cerebellar atrophy as well. Is that right, Nihaal?
Yeah, it has. Yeah, child has.
And
they are
GRE
pointing towards GRE is normal. Yeah. I was thinking mitochondrial based on the entire picture, but which gene? Maybe the entire mitochondrial needs to be covered, as Vivek has mentioned.
And sometimes if mitochondria are reanalyzing the whole exome because it's always something comes out they have not mentioned, and then when you tell them, then it comes out of the discussion. So sometimes a good geneticist can, if they have their team, they can independently reanalyze the whole exome. So you've got Gangaram there, so you can always send the patient there to Dr. Sunita or Dr. Ratnapuri. And
Okay.
their neurometabolic, Sunita is already neurometabolic. So they can reanalyze
Okay.
mitochondrial sequencing if it's normal, because at multiple times it has happened. Because they don't discuss with us, they just assume those genes were not important. But when we have a discussion and we reanalyze them and we tell them, then sometimes things come out, things which they have not considered important.
Okay. So they will consider for reanalysis and sending the panel as well. Thank you.
Yeah. Thank you, Saini. If you get a follow-up, please let us know.
Yeah, sure.
Okay. If there are no further comments, we'll move on to our next case. It's from KIMS. We have Dr. Aarti or Grishma. Rupesh, just make Grishma as panelist. Rupesh, are you there? Grishma is there in the attendees. Just make a panelist. Okay, sir. Is it done? Okay, Grishma, I think I see you in the panelist. Grishma, if you're there, go ahead.
Good evening, sir. This is a 1 year, 6-month-old girl, first child of non-consanguineously married couple with normal birth history and normal developmental milestones. She presented with 1 month history of neck tilt to left side and chin to right for 1 month. There is no restriction of neck movements, no unsteadiness of gait, no developmental regression, no weakness, otherwise well child. On examination, there was no cranial nerve deficit. There was torticollis to left and gait was normal.
Okay. So after this, anything on the image over there?
No, she is
Okay.
a perfectly normal child. Otherwise, only there was a torticollis. No other
Okay.
symptoms or signs.
Okay. All right. Okay. I have MRI. On top is a heavily weighted T2 sequence, axial sections, non-contrast, and you can appreciate there is a mixed solid and a cystic lesion centered in the fourth ventricle, extending up to the right, almost up to the right cerebropontine angle. The solid aspects are more along the anterior aspect, whereas there is a multi-faceted cystic lesion along the posterior aspect. This is non-contrast C1 sequences over here. These three, again, you can appreciate the solid content and the cystic content along the posterior aspect. DRE sequences, possibly some punctate areas of blooming on there in the solid components. Diffusion, there is diffusion, some degree of diffusion restriction along the solid components, as you can appreciate over here. High on the DWS sequences with reversal on the ADC sequences. That sequence, you can appreciate the extent of the lesion along the craniocaudal aspect. It's going from the fourth ventricle up to the cisterna magna. The cystic components are more posteriorly, and it is indenting on the brainstem structures. Post contrast, there is some degree of inhomogeneous enhancement of the solid components. The walls of the cystern septa also demonstrate some degree of enhancement. Spectroscopy wasn't done. So I think they wanted the approach to the lesions, posterior fossa lesions. So this is a paper, I think, from the Great Ormond Street Hospital and CHOP. And if you follow the algorithm over here, the lesion is primarily focused along the fourth ventricle and the foraminal ashcam. The main component of differentiating component is the diffusion changes. So if there are diffusion changes in a posterior fossa lesion, to possibly consider the abnormalities such as medulloblastomas and ATRT. And the child's age is 1.5 years of age. So if diffusion changes, the age is not a strict criteria, but the younger age group children usually have ATRTs, where the medulloblastomas are slightly the older age group, but not very scientific. These are examples of ATRTs, which are differentials in our case. If you see this image over here is similar to our case, has solid and cystic components in the extraaxial space. So this is one possibility. Medulloblastomas, especially the wingless pathways medulloblastomas, which are usually laterally located, can be a differential. The sonic hedgehog is usually in the parenchyma. The group 3 and group 4 are usually centered in the fourth ventricle. They do not extend laterally. So the primary differentials are ATRT and the wingless pathways medulloblastoma. Yeah, Grishma, if you can just update us with the HP report.
The child underwent surgery, and the HP report came as atypical teratoid rhabdoid tumor, CNS, WHO grade 4 in fourth ventricle, with GFAP was positive, EMA positive, and SMA was positive. And after surgery also, they have taken MRI.
Okay. Yeah.
Okay.
So. No, I don't have the post-op images, but okay. So you mentioned the frozen report suggest of ependymoma. Was that also in a prior report or?
Initially, after the first MRI, the differential one was ependymoma.
Just the differential, not in our case, but which can be seen in cystic lesions or racemose LCC. She can also have these multiseparated lesions, but the solid components are usually less or not existent as seen in our case. With that, I'll open the case. If anyone has any comments to make, any differentiating factors and approach to posterior fossa lesion.
I have nothing to ask. This is just a good teaching point, a learning memory that any new onset head tilt is suspicious of a tumor in the posterior fossa and needs imaging. Urgent.
Yeah, I think that's absolutely valid point. Any new onset torticollis imaging is mandatory. Very, very valid.
All right. Yeah. Thank you, Dr. Lokesh. Again. So, Grishma, we are agreeing with the HP report. Yeah, and the imaging also somewhat fits. So, yeah.
Okay, sir. Thank you.
Thank you. Okay, over to you next case.
One more case, posterior fossa tumor. Again, 2-year, 3-month-old. This is the first child of non-consanguineous marriage. This child presented with 1-week history. There was decreased activity for 1 week and lethargy for 3 days, and decreased oral intake for 3 days, and 3 episodes of vomiting 1 day prior to admission. And child actually fell down from cot. So therefore they have taken CT brain and referred the child for further management. But on arriving to ED, child has poor GCS, and child got intubated. Child had anisocoria, features of raised ICT, bradycardia, hypertension. MRI brain was done. And child was shifted for surgery, but the child having even after giving the anti-edema measures, child had features of raised ICT. So EVD was done, and child was shifted to PICU. But this child had a stomy course, and the anisocoria persisted, and fourth day of admission, actually child died.
Okay. So I have 2 sets of images. First one is the CT, is that right, Grishma?
This is a post EVD.
Okay, so first is the MRI. Okay, all right.
Yes.
Okay, so yeah, so we have again a posterior fossa lesion. As you can appreciate, on the coronal sequences out there, the T2 extraaxial lesion along the left, so left aspect of the infratemporal parent region out there, you can see it's T2 hyperintense, slightly iso-intense features, but predominantly hyperintense. It is going up to the prepontine region along the anterior aspect. It's engulfing the brainstem structures out there, causing some degree of hydrocephalus. As you can see, there's direct ventricles with periventricular interstitial edema. These are again axial sequences. You can appreciate the extent of the lesion out there, predominantly on the lateral aspect, seeping through the CSF spaces along the anterior aspect of the brainstem structures. On the SW sequences, there are some areas of punctate areas of blooming on the SW sequences, possibly some degree of hemorrhage or mineralization. The diffusion various sequences, they're predominantly T2 shine through images, as you can see, the hyperintense on DWI, but on the ADC sequences, is predominantly demonstrating facilitated diffusion. So it's again posterior fossa lesion along the extra-axial aspect on the left side, seeping through the CSF spaces. We're thinking of prime differentials of ependymoma. Given the age and the location of the lesion, primarily thinking of the posterior fossa type A ependymomas. Usually it's located along the lateral recess, have poor prognosis. So this is one of the prime differentials we thought of for this case. Post of, I think, CT demonstrates there is some degree of parenchymal hemorrhage and subdural hemorrhage, and also cerebral and cerebellar edema, which has progressed in comparison to the MRI scan. So the imaging consideration, we're thinking of ependymomas, and I'll open the case. Do we have a diagnosis, the Grishma? I think the child passed.
One of the differential.
Okay.
So another question was whether it is again any rhabdoid tumor, ATRT.
Okay. Yeah, I'll open the case.
I have seen somehow similar case, also an extra-axial lesion, acute dramatic course from the cerebral pontine angle, and it proved to be a choroid plexus carcinoma. There is choroid plexus in that location.
Do we have contrast? I don't think we have contrast, Grishma. Hospital. No.
Contrast.
No, we don't.
Okay.
So ependymoma and ATRT is the question. If anyone has any point.
Why did we not do posterior fossa cranectomy and why did we do EVD? Because this would be counterproductive here. Because we should just have removed the bone and that would not have compressed on the midbrain. Because EVD will cause reverse herniation.
Yes, sir.
Because actually, this child looked possibly, if we had removed the bone, we would have, relaxed the pressure. While by putting the EVD, we have increased the, there is a reversal of flow.
Yes,
so that is the problem. Neurosurgeons often just put the EVD. Somehow the dynamics has to be sort of discussed, especially these posterior fossa issues where it can be counterproductive. Because if you have removed the bone, posterior fossa, there would have been space. We didn't need to put in a shunt.
Yes,
or if we put in a EVD, we should always do it with a bone removal with EVD. And even if the child is not stable, one can still do it.
Okay, sir.
I think hello, Nihaal, I'm
Vijay. Yeah.
I think it is a very important point Dr. Vivek is telling that many times I've been neurosurgeons always, even for a posterior fossa mass lesion, they will try to decompress by an EVD. And many times I've seen this happening and patient dying. So even in this, very where discussions are happening, this is happening because in an emergency, patient comes with bradycardia, the neurosurgery will always try to put an EVD. And here, the best course is actually to decompress the posterior fossa along with an EVD.
Yeah.
I think more discussion should happen with the
more MDT, sir. Grishma, was it discussed by any chance or?
It was discussed, our consultant was telling it was posterior fossa decompression was the otherwise upward herniation. There is chance, madam was telling. But we didn't have proper discussion with neurosurgeons. We will do so. Thank you.
Okay. All right. All right, Anas, over to you.
Yes. So this is a 12-year-old female child. Uh, so, uh, so things started when she was 2.5 years of age. She initially had febrile seizures and then afebrile seizures. They were of occipital stimulus. She would have this sometimes visual auras, staring look, and fearful look. She was on anti-seizure medications, so it was well controlled for a while, on and off. And she was under follow-up. So now she's 12 years old. The current issues were she's has history of vomiting since past 2 months, with early morning vomiting, headache, with and without food as well. And this would not subside with oral antiemetics. She would require repeated IV fluids and IV antiemetics. Otherwise, she had some baseline mild cognitive issues and some difficulty at school, but that was fine. And she had some clumsiness to her when she would do her normal motor activities, but she would do them without any no further. She could do her activities of daily living independently. But in the past 2 months, there was some worsening in fine motor function. Like she would started to have tremulousness, and when she's walking, she's adapting a wider base gait. So now they came to us because the headache, the vomiting frequency was increasing, and she was becoming dehydrated. So prior to when she had this occipital onset seizures, a neuroimaging was done at that point of time. It was non-conclusive, inconclusive at that point. Genetics were sent, and she was evaluated for cyclical vomiting syndrome as well. So this we have imaged her now.
Okay. All right. So this is a follow-up scene, I think, done last week itself. Some degree of cortical reduction, volume reduction, but predominant changes are in the thalamic, the central median thalamic nuclei as bilateral T2 hyperintensity abnormalities, the periaqueductal region and the dorsal aspect of the midbrain out there. Again, you can appreciate the T2 hyperintensity. Cerebellum in terms of volume it looks okay, not very significant atrophy. Again, the flare sequences demonstrate the midline edematous changes along the third ventricle out here, the periaqueductal region, and the dorsal aspect of the midbrain, the inferior colliculus. Possibly there is some degree of hyperintensity also in the mammary bodies and the optic tracts on either side. So these are the main changes we have seen on the T2 and flare sequences. On the diffusion weighted sequences, there was no areas of restricted diffusion, no abnormalities in terms of mineralization or hemorrhage on the SWA sequences. Again, this is just a sagittal aspect of the periaqueductal abnormalities, some degree of atrophic changes in the corpus callosum and the anterior vermis. The predominant changes along the midline. Spectroscopy was done, though the baseline, I think, is not very stable. The peaks are slightly abnormal out here. I'm not sure if these are artifactual, but no significant peak stands out, or is it mostly artifactual? I think Dr. Vijay might be helpful in confirming that. So based on the imaging, I think, yeah, Anas, if you want to, was the imaging the labs done after the imaging or is it before?
Yeah, the labs were done. Few were done before and few were the period after. So
Okay.
when she was admitted, we had done TMS earlier. It was normal, but and even earlier, as part of our evaluation, TMS ammonia were done. TMS was normal, but her CSF analysis was done for urine and the CSF and blood glycine. That was normal. Just slightly elevation in the urine glycine levels, but CSF glycine were normal. TMS, biotiness were normal. Lactate was 4.8. This was done recently when she was admitted in the current. So we have genetics, but it was a BUS. Urea cycle.
Okay. So it doesn't match, the first analysis doesn't match NAGS. Is that right, Anas?
Yeah. Yes, sir. It's not a match considering she never had hyperammonemia.
Yeah. Okay.
Yeah, the question here was, Nihaal, this child with this MRI was done after she was having recurrent vomiting for almost 1 to 2 months. And then she was unable to walk for last few days. Whether, as mentioned, it could be something like acquired sort of Wernicke's encephalopathy kind of presentation, absolutely unrelated to the primary disease. Because the reanalysis of the genetics for all the Lee's mitochondrial pathology turned out to be negative as well after this scan came to us. So that was the question. Is there any way to say it is acquired Wernicke's versus genetic?
The another variant that also I think doesn't match the blockage.
Yes,
Or
sir.
Anas. Yeah.
No other
Yeah,
variant
that's
we could pick up. Yeah, no other variant we could pick up other than the NAGS variant.
Okay. This was also mentioned, I think, location SLCA9. But the imaging
in
doesn't
the
match
addition.
in the additional variants. Yes.
So their reporting is wrong. Their reporting is so wrong. They should not have put red likely. It is a heterozygous and it is autosomal recessive. They shouldn't
It's
have.
not a match. Yeah, it's not.
No,
yeah,
not even a match. It is not
No,
homozygous.
it should be a homozygous.
And it says likely pathogenic in red in classification. They should really change it because one, you should not be putting a likely pathogenic in a second page, and it is not likely because it's heterozygous.
Yeah, I think somehow whatever the pattern they use, they give something in the second page. These reports. Yeah.
No,
Okay,
that's
yeah,
because we missed a patient of immunodeficiency state where they put on the second page the immunodeficiency gene as likely pathogenic and first page Paul G as VUS. And people miss the second page. And the child had that gene. So it's just for us to be vigilant when they send that the first, that's something there might be on the second and third page. Not in this case, but I've had two such cases before.
Yes, I'll open the case. Yes.
Are you considering to look for the mitochondrial genes and not only the nuclear? Because you have elevated lactate, you have an MR which is in keeping with the mitochondrial disorder, you have increased alanine in the urine.
Yeah, we have looked for that, Prof. We didn't find any variant. After this MRI, we looked for it. We reanalyzed the nuclear and the mitochondrial genome.
Okay, sorry, I missed that point.
Yeah, sorry, I didn't mention that again. Yeah.
And can they do a skin biopsy and check for respiratory enzyme? Is it worth doing it here?
If we say it is not acquired possibility of acquired Wernicke's, then probably we'll do a muscle biopsy and respiratory enzyme analysis.
Right.
What is your hypothesis? How are you going further? I mean, to have a negative mito and nuclear panel does not exclude a mitochondrial disease. The yield is at the maximum of 60%. So this is perhaps still a mitochondrial disorder.
Yeah, so we'll repeat the lactate again when she's stable. If it is persistently elevated, we'll plan a muscle biopsy with respiratory enzyme analysis.
At least the imaging point of view, Dr. Yogesh, they are thymine sensitive regions, or what we say centrally in the median thalamic nuclei, the periaqueductal region, mammillary bodies, these are all related to thymine deficiency, but I'm not sure if I can point out if it's acquired or genetic.
Yeah, sure. I think we'll repeat the lactate when she's stable and then follow it. Thank you.
All right.
Thank you.
Okay, Anna, so to you.
Yeah. So when this child presented to us, he was a 10-month-old male child born to third-degree consanguineous parents. So he was referred from the pediatric OPD. Child had non-venous vomiting on and off for 15 days, fever for 2 days, following which they noticed some coliform movement to the tongue. So there was history of domperidone usage. So initial suspicion was it could be because of the domperidone, but when reviewing, the dose was appropriate. And child had perioral dyskinesia, bilateral tremors of hand, cogwheel rigidity, brisk DTR, and even pseudobulbar weakness was there. So initially, when the child presented to us, we had done neuroimaging.
All right. Again, predominant thalamic region, central lesions, some degree of pulvinar involvement. You can appreciate now there is some degree of, there is like more volume loss in the supratentorial brain. Sustained hyperintensities of the globus pallidus, more on the right side, but predominant changes are in the median thalamic nuclei and the pulvinar nuclei. Brainstem also demonstrates some edematous changes, as you can see over here on the midbrain, some degree in the pons, and also dentate nuclei. What was the age, Anas?
10
10
months.
months. Okay. So 10 months maybe the dentate nuclei is equivocal, but the brainstem structures, the median thalamic nuclei, the globus pallidus demonstrates abnormalities on the flare and D2A sequences with a backdrop of cerebral atrophy. Diffusion, again, there was no restricted diffusion. None of the lesions or abnormalities demonstrated restricted diffusion. No hemorrhage or necrosis on the SWA sequences. And on SAG, yeah, you can appreciate there is some degree of edematous changes predominantly along the dorsal brainstem. Again, similar to the previous case, differentials would be same. Before that, Anas, if you just want to update the labs.
Yeah. So at that point of time, because child had a fever and other URTI, flu panel was sent. It was influenza A positive. We had done LP as well. That was mixed. CSF protein and sugars were normal. Cells 5 now. And we have also sent mock as part of evaluation of negative as well. TMS biochemistry was sent, which we later got as normal.
Okay. I don't know how it projects, but thalamic lesions, these are differentials. Wernicke encephalopathy again has somewhat similar imaging picture. Biotin thymine has was a clinical suspicion. Is usually more dorsal striatal involvement, more cerebral cortex involvement. The median structures of thalami are usually involved, which is also seen in our case, but some features I thought were missing. So it doesn't completely rule out, but not typical imaging feature for biotin thymine. Yeah, with that, I'll open the case. We're thinking of infection versus metabolic disorders, and if metabolic, which metabolic disorders to consider.
As you have mentioned the current admission already.
So the child came to us 2 weeks earlier, and at that time, child had child presented with pneumonia. It was admitted in the pediatrics. When we saw, there was some aspiration component. So parents were counseled for gastrostomy, and so they wanted to consider it, and they had gone. So child again returned 3 days later with presented to the ER with a history of rapid breathing. And when we saw the child had very shallow breathing and was unresponsive at the time of admission. And despite resuscitation, child could not make it.
Did the child ever respond to thiamine supplementation?
Thiamine was given. No, thiamine and biotin were tried. So on follow-up, the child became very rigid and hypokinetic. There was a plateauing of the milestones, and child, despite adding supplements, mitochondrial supplements, and thiamine, biotin, child did not improve.
CSF lactate? Yeah, Dr. Udani, there are some necrosis in the thalamic abnormalities.
Yes, I was wondering which, I mean, it's a little unusual to have no restrictions. Would it be a mitochondrial disorder again?
Yeah, that is a possibility. CSF was done anytime, Anas?
Yes, CSF was done, analysis was done, but lactate was not sent at that point. CSF analysis was normal.
Okay, there's a comment from Sridhar, mitochondrial tRNA can progress rapidly. Okay.
I agree. This is likely or compatible with a mitochondrial disorder. It can be very rapidly progressive, and I've also seen rapid onset of core A for movement for a certain time, and then this can be abolished, and on short-term follow-up of MRI, you'll see new lesions. And
Yeah,
also the
this
shallow breathing is compatible. Lee-like in the very broad sense.
yeah, this MRI is from November. I don't have a new.
Yeah, repeat imaging was not done.
Yeah, he came in collapsed with multi-organ dysfunction, ferritin of 6,000. This admission.
So I think yeah, multiple episodes. Yeah, that favors not a single point attack such as an infection. So I think mitochondrial would be high on the consideration. Okay, there's a question of can this be inflammatory cytokine release syndrome followed in influenza?
This episode, yes, we had considered inflammatory cytokine storm because he had profuse coagulopathy, bleeding from multiple sites, and also, as I said, ferritin was very high, and there was a WBC count which was around 30,000. So there was evidence of significant inflammation this admission. Previously, it was not seen. This is the first time we presented and succumbed.
Okay, I think yeah, we're thinking mitochondrial dislocation with multiple episodes of infection and inflammatory changes. I don't think we'll get an answer. Is that, or is it possible to get a analysis done?
Probably will not get an answer.
Oh, no. Yeah.
Thank you. Thank you.
All right. There are no further comments. Then I think that was the last case for today. If anyone wants to make any comments, the forum is open. Otherwise, we meet again 2 weeks later.
Can I show a case?
Yeah, Dr. Guran.
But I don't know how to share from my mobile. I'll try.
Okay. Or you can send it to me and I'll open it from here if you have the.
Okay, I'll do it.
Thank you very much. Have a good time. Stay well.
I can be a one case if you have time.
You have one case. Okay. I have plenty of time today.
One case on the spot. Let's see if we can do it.
Just a minute.
Yeah. I think for the previous case, if you had follow-up imaging, that would have been helpful. There was progression or extension of lesions.
Yeah, though it was done in November and then he came collapsed in 2 months.
I agree.
Very short interval.
Yeah.
Nihaal, I'm sending to you. I hope you get it.
Okay.
Unfortunately, somebody who just asked an opinion on the WhatsApp. It's an interesting case, so I thought I'd just show it. If we have it.
Okay. Let me see if I can open WhatsApp. Yeah.
You want me to send it by email?
I can open on WhatsApp.
Just to give you a short history, what I got from Dr. Trupti, I think her last name is Bhosle, I'm not sure. She basically
yeah, please go ahead.
Yeah, I just call her. So this was a kid who basically came with he was a big boy. He went to a big girl, 14 years or something. She went for a school trip and had a lot of motion sickness, and there was motion sickness in the history of motion sickness. And then she was otherwise okay, no headache, nothing. The next morning she started vomiting, and she vomited a lot, and slowly went into an encephalopathy. Then had seizures, and behavioral changes. And then finally, she started having intermittent posturing. The CSF was essentially a very high sugar. I mean, CSF sugar was 90. They haven't done a blood sugar. And protein was, 2.21. So very low protein. No idea why. And only one cell. The first MRI was normal on day 2. The EEG showed diffuse slowing, and there was nothing else really.
You can open it on WhatsApp.
Actually, there's one, video kind of thing which is.
Yeah, I've got the video. All right. So this is the first MRI, is that right? The one in the films?
I'm not sure.
Okay.
I think it's probably the first MRI.
Okay. All right. So
No,
flare
actually, if you
sequence.
look at the bottom,
Yeah, there is. Yeah.
is it flare or is it?
No, the one on top is flare. The one on bottom is
lower
diffusion.
part? Yes, if you look at the cortex over there, it's quite.
Then maybe put up a diffusion. Okay. On the T2s, you can appreciate there is edematous changes. Bilateral thalami, bilateral cortex subcortical regions diffuse edematous changes on either side. Cerebellum also appears to be slightly edematous. Let's see if we have a diffusion. Okay. So on the diffusion sequences, you can appreciate extensive cytotoxic edema, deep white matter, subcortical white matter, with some degree of periventricular sparing, what we typically term or see in patients with ALARD type pattern. There is also involvement of the thalami on both sides.
But the only thing is, isn't the cortex also significantly involved in diffusion? Because this might be a delayed film, and you might, there might be normalization of the gray matter diffusion, and then now you're seeing mainly the white matter. So I'm not sure it's.
So we posit there here. If you see the ADC sequences, they are predominantly in the white matter, the reversal. The cortex is edematous on the T2s, flares, and the diffusion, but the predominant diffusion changes are in the white matter, Dr. Udani.
Right, but doesn't the gray matter diffusion changes normalize earlier than the white matter?
Yeah, they do.
They do. No, that's what I'm saying. If you look at the adjacent sequence, which is there, you'll see that is the.
Yeah, I agree. Cortex is also edematous. Yes. I think nothing is there on the contrast. If I'm.
You were just showing as a massive edema, and there was some tonsillar herniation.
So the left ventricular vessels are, they're attenuated, but I think that is secondary to the edematous changes.
Right. I mean, they're labeled in acute encephalitis as usual, but I don't know what. There's no fever ever, and Any ideas?
Did she have a trauma?
No. Not apparently at least, but she just had this motion sickness, vomited, little drowsy, became more and more drowsy over the next 2 days, and then started throwing her seizures. And the whole
I think the brain, the changes are, I think, more what we see in the ALARD type pattern, Dr. Udani. This can be secondary to infection or secondary to seizures, especially if they're biphasic. But the underlying cause is usually an infection, which we find on the side, the diffuse excitotoxic injury, or commonly what we term it as ALARDs.
No, but what I want to ask you, why do we call it ALARD? Because if it is involving the cortex as much as the white matter, wouldn't that
I know that we have previously discussed over here also. It's slightly, the term is slightly, doesn't point towards the exact abnormalities, but what we classically have termed it as is used in terminology is ALARD, but I usually use the diffuse excitotoxic brain injury.
Yeah, I think that's probably maybe seizure related, though the EEG, whatever they said, we did not show any ictal changes, but that may have been there before. I don't know.
Any toxic related changes? I mean, toxicity.
Nothing
Any
obvious
toxins?
because when she went to a field trip, and it's always possible that she was exposed to something over there. They even look for snake bite and all that. But I don't think this is the kind of picture you get. Okay.
But
Okay, so yeah.
fulminant MOG has presented like this. We have discussed 2 cases, even with LRAD changes. So NMD was mentioned, that's how it doesn't often present, but MOG has to be ruled out. Yeah.
No, I think they've already sent them. I don't know if they've done the MOG, but they've sent off the autoimmune panel, including the MOG. NMDA was ruled out. So I asked them to do everything, including the MOG.
Because in such situations, NMDA would be way down. MOG has to be top because as we are realizing,
Yeah, they get these encephalitis. What about these thalamus changes? I mean, that could occur in MOG, but do they occur in alert as well? Because if you're looking at thalamus, the
they are, I think,
pulvinar
more.
seems
I think more seizure-related abnormalities.
That's what I'm saying. I think it's probably a status-related change. And the status-related change has got severe, probably she has having non-convulsive, I don't know what kind of, and therefore this kind of, because when the pulvinar is involved along with is the hippocampus also prominent?
Hippocampus, yes.
Yes, so I think it could be status-related, you get changes in the hippocampus, in the pulvinar, the circuit, and you get in the cortex. And then you may get secondary changes in the white matter. So I think maybe that's what's happened. I don't know. I can't really.
So I would term it as exotoxic brain injury secondary to seizure or infection of cytokine storm, as put in chat. All the 2 or 3 possibilities to be ruled out.
Sure.
And then we have, let's see, anything else on the chat is the Japanese encephalitis. Whole panel. Okay. Yes. I don't think a panel was sent yet.
No.
This is a very recent case, so yeah.
I saw it yesterday, last night, actually, on the WhatsApp itself.
Okay. Dr. Kavita has mentioned secondary to cytokine related changes. So, yeah. For toxins, so yeah, please go.
To add to the confusion, crazy differential diagnosis. Ion channel disease, CACNA1 mutations. There are patients reported who have kind of fulminant edema, even lethal sometime.
Yes, that's the reason why I thought of even a familial hemiplegic migraine, because CACNA1 can come with a massive cerebral edema and all that. And there was a lot of motion sickness, and she was quite sick when she came. She started vomiting a lot. And then she went into this. I was wondering whether even that's a possibility. And I think we should send the whole exome at least. I remember reading about a case of massive cerebral edema with CACNA1.
If you come to a diagnosis, please let us know that we can learn.
Yes, definitely. Okay.
All right. Let's see if anyone else is okay. Thank you.
Thank you.
Sridhar has mentioned Chanter. Sridhar, we have seen Chanter, but they really, as you have seen, cerebellar hippocampal basal nuclei edematous changes. This is more confluent, which may not fit Chanters, the typical Chanters. And they're more in the adult age group, I think, Chanters, if I'm not mistaken. Yeah. Okay. Thank you. All right. Thank you. Thank you, Dr. Rani. Thank you, Dr. Lokesh. Again, Dr. Vijay, Dr. Vivek, everyone for tuning in. And we'll be back in 2 weeks' time. Kindly send in your cases 2 days